Welcome everybody to our last presentation, our last PowerPoint, which is called walking. So please open your PowerPoints and we will discuss a couple of issues over here. It's a fairly easy and straightforward PowerPoint. Information is not really difficult to understand. So hopefully this last presentation is going to be a bit shorter. But anyway, walking is a very basic activity we do every day, and during the walking, the interesting part is that during the basic walking, the muscles using the least effort of all the activities we do on in our daily lives, which is a little bit puzzling. We still don't fully understand how this biomechanically happens that people can walk fairly great distances and yet they do not tire themselves as quickly as doing performance or pretty much any other activity. Although this is not fully understood yet, the concept was already introduced in 1836. So it's long time ago we already know that this happens. So let's go to the next slide. Definition of terms. Gait. Gait is another term simply stating a pattern of walking. So we have different patterns of walking throughout our lifespan, of course. So there are big differences in gait when it's a small child. We're talking about a toddler, and then we're talking about a young adult, and then we're talking about the middle-aged adults, and of course geriatrics. So our gait changes continually throughout life. It takes approximately 7 years for a child to develop the proper way of walking or the proper gait then used throughout the adulthood. What is cadence? Cadence is simply how many steps are you making per minute. I would like you to be very careful with those numbers you see on the screen because 100 steps per minute for average adult. So the question is, who is average? You have somebody who plays basketball and is 7 feet tall, and then you have gymnasts who are 4.8. Their gait are going to be different, of course. Their cadence is going to be different, most likely. And of course, so we have to take that average person doing average walking, not when you are fast pacing to work or fast pacing through hospital or slow leisurely Sunday evening walk. So this cadence again and all the rest of the numbers we're going to discuss today, take this on average adult, again not a child, not a geriatric necessarily, on performing daily activities. Okay, so having said that, let's go to the next slide. Angle of feet in stance and gait. So in normal stance and gait, the feet are externally rotated between 5 and 18 degrees, and you can see that there is a big gap between 5 and 18 degrees, and all in between we're gonna consider it normal. Next slide says base of support in gait. So the width is very important. Of normal base, the width is between your feet. It's about 7 to 9 centimeters, or in other words 2 to 4 inches. Well, again, this is considered a normal walk for an adult, but in the rehab, of course, we know that if somebody has a problem with balance, for example, we are always advising our patients to stand shoulder width apart, which is significantly wider stance for safety reasons. A normal step length is about 15 inches. Again, this number is could be somehow misleading, because if you have a considerably taller person or shorter person, the difference can be significant, but nevertheless 15 inches would be considered normal. Center of gravity in gait. Well, center of gravity oscillates vertically approximately 2 inches during the gait cycle. So what you can see on this picture over here, it shows actually a part of pelvis, or the superior aspect of pelvis, the inferior vertebral column, and you can see that as we walk, and you can observe actually the head. Perhaps the head is going to go up and down, up and down, up and down as we are moving forward. So this is absolutely normal. That should happen. And again, it's approximately 2 inches difference. Okay, let's go to the next slide. Pelvic rotation in gait. In swing phase, we're gonna talk about two different phases just in a minute, but in swing phase, the pelvis rotates approximately 40 degrees forward. Opposite hip acts as a fulcrum for this motion. Now we do this intuitively. It's not much to talk about, except that now we know that as we're moving, the pelvis from the zero position shifts about 40 degrees, again in a normal way of walking or normal gait pattern. Okay, let's go to the next slide. Lateral shift in gait. Pelvis and trunk shift approximately 4 centimeters, which is like 1.5 inches during the gait cycle. So as we walk, and males and females, as we walk, we're shifting our pelvis left to right, right to left. This is more prominent in women, and you can clearly see that when you observe a woman walking and a man walking. Why is the difference in this lateral shift? Well, for a couple of reasons. First and foremost, the pelvis bone itself is wider, it's heavier in females as opposed to males. In addition, the normal build of a woman is thinner torso and then wider hip, when men are more straight up. And so the appearance of shifting, lateral shift, appears to be less for men than for a woman, when in reality it's approximately the same. Okay, let's go to the next. Gait cycle. We have a stance phase and a swing phase, and let's talk about those one at a time. So let's go maybe to the next slide. Okay, so the gait cycle is initiated as soon as the foot contacts the ground. Okay, so we're gonna, the point 0, okay, the foot contact is normally made with the heel. So if you have a healthy gait and normal healthy feet, you're gonna start your walking with either left or right foot hitting the ground with your heel, and then freeze the picture. That's your starting point, okay, or point 0. This is also called heel contact or heel strike. Okay, the cycle ends as soon as the same foot touches the ground again. The same foot. This is the key over here, and we're going to discuss this in a second. So gait cycle could be called, or it is sometimes called, a stride. So gait cycle and stride, it's equivalent. However, gait cycle consists of 2 steps, and we're going to talk about that in a second as well. So gait cycle is a distance between the same foot touching the ground. So it's twice as long as the step. Imagine you can put your right foot forward, then left foot only as far as the right foot. That's a step. But it's not a normal gait, because in normal gait you would take right foot and the left foot will pass by the right foot, and you would put the foot down one step ahead of the right foot. That would be considered a full gait or a stride. Okay? So one step, in other words, is a half the distance of a gait cycle or a stride. A full gait cycle can be divided into two major phases, of course. Stance phase counts from right heel contact to the right toe off. It occurs as the right foot is on the ground supporting body weight. And of course, if you start a gait with your left foot, would be the same thing. Instead of right, you would say left. All right, so let's take a look at the slide, which is titled Stance Phase, and the darker leg is the one which we're interested in, and the lighter one is the one which we're going to talk about it later. So stance phase, we can divide it into different parts. All right, so it's heel strike, foot flat, mid stance, and finally push off. Okay, so again, you can see it on this drawing over here, starting from the left hand side. The person is standing in zero position. Okay, nothing happening yet. So this is your heel strike. Okay, then we're shifting the balance, we're moving the mass of the body forward, and we're ending up on the flat foot. And pay attention to the, in this case, left leg, which is still behind the body. Okay, the mid stance, you are slightly moving your body mass, your weight forward, closer to your toes, and at the same time, the leg which was behind you, it's already coming in. And the last phase, the push off, is when the working leg, the stance phase working leg, you find it on its toes when the other leg is already forward. Okay, and the cycle starts all over again, the same one, but this time, according to this drawing, using the left leg, the left foot. Okay, so let's go to the next slide. Swing phase. Swing phase, now we have three different stages. Early swing, which is called also acceleration, or when you actually gaining the acceleration to push the body forward. Mid swing and late swing, which you actually want to stop. You want to stop the body, you want to decelerate. And again, on this particular drawing, you can see the darker leg with the foot, which works, and the one on the left side, the white one, it's the one we already discussed in the previous slide. So you accelerate the foot as the foot is into back, but already airborne. Then mid stand when the foot gets in the midline, towards the midline, and the deceleration when the foot is already up there in front of you. Now you want to lower that foot down. Okay, let's go to the next slide. Problems in stance phase. Heel strike, antalgic gait, heel spurs, weak quadriceps, drop foot, and fused ankles. So let's see what we can say about a couple of words about each of them. Antalgic gait. Person tries to bear weight on the involved or painful extremity for as short time as possible. Normally, we as humans do not like pain. Some people do, but that's a different story. Normally we don't. So body rejects the pain and try to find a way to avoid that pain. So how are we going to avoid the pain when we're putting our foot down and we are compressing some tissue, bone or soft tissue which causes pain? We are going to hop. We are going to take this foot off the ground as quickly as we possibly can without jeopardizing, of course, the general walking pattern or the gait. So it does look very awkward. People kind of hop, and you can see this very clearly if somebody is in pain. So it's called antalgic gait. Let's go to the next slide. I have a very short YouTube clips which you can just take a look at that. They are super short. Maybe you can find even better ones. Those are the ones I found for you. Take a look at that. All right. Heel spurs or bony growth may cause pain on heel strike. Person may try to hop to avoid heel strike and accompanying pain. So this is underlying problem, or one of the underlying problems of the long list of problems which can cause this this abnormal antalgic gait pattern. Okay. And again, I got a short YouTube, few seconds, literally few seconds long, about that. Weak quadriceps. Persons with weak quadriceps will not be able to fully extend knee for weight bearing in stance phase. Person may compensate by pushing knee into extension. Okay, so this is very characteristic pattern of walking. Usually you're going to see this pattern of walking with post-stroke patients, sometimes with spinal cord injuries or any other disease really which can cause significant muscle loss, or the strength and the power of the muscle decline, that the quadriceps gets so weak that literally cannot work properly, and people sometimes help their own legs with the arms. Okay, again you have a short YouTube video. Weak dorsiflexors may cause foot to slap down after a heel strike. Well, this is actually very common with stroke patients. I have seen it many times in my professional career as an OT. Dorsiflexors simply don't work when person survived stroke but was left with weak side. Sometimes the upper arm doesn't work at all, or is even contracted. You can see people walking in this kind of position or in those positions, right? And the dorsiflexors don't work either. So how the person can compensate for that loss of that ability of the foot to go up or dorsiflex is by bringing that leg very high. So you can see stroke patients sometimes bringing the foot very high, the foot drops, otherwise would catch the floor. So in order to avoid that, they're gonna bring the foot very high and kind of slap the foot down. All right. So this is, I've seen it many times with CVA patients. Okay, let's go to the next slide. Again, you have a very short YouTube video about weak dorsiflexors. Problem in stance phase, mid-stance, pes planus, weak quads, problem in the heel strike as well. We already discussed that, but this is in the in stance phase. Weak gluteus medius and weak gluteus maximus. Okay, so let's go to the next slide, and we have pes planus gait. Weight not distributed evenly over foot surface, may develop painful calluses on metatarsal heads or corns on dorsum of the toes. So with this pes planus gait, of course, we are going to have problems with footwear. Not all shoes can be worn, and of course people buy the wide shoes, oversized shoes to kind of accommodate that disability. Okay, let's go to the next one. Painful calluses and corns. So this just simply shows you how the arch can actually drop, causing the foot to go flatter, therefore wider, and other problems with shoes and calluses, corns, etc. associated with it. Okay, let's go to the next slide. Weak gluteus medius. Weak gluteus medius. Okay, so we talk about the importance of muscles. Gluteus medius, gluteus maximus, right? And we said that gluteus medius is the primary muscle of lower extremity abduction. So when weak gluteus medius has no strength, no power to abduct that hip correctly, and what people tend to do is kind of straight up the leg and hike the hip. So to accommodate the weak muscles, they are going to raise the entire hip, and this type of gait, of course, looks very awkward, and you can spot it right away as well. Okay, let's see. Right, this weak gluteus medius, this particular gait, we can also call it hiking, because literally we hike our hip in order to accommodate for the weak muscles. And this could be caused by gluteus medius weakness, paralysis, but also in other cases, like for example fused knee. Right? We can't bend our knee in order to propel ourselves forward. Therefore, what we're going to do, we're going to hike our hip to accommodate and create the distance between the foot and the ground. Okay? All right, let's go to the next slide. Weak gluteus medius. So you got two drawings, two pictures over here. On the left hand side, gluteus medius lurch, and on the right hand side, Trendelenburg gait. Basically, this is the same thing. Those are just different names for the weak gluteus medius muscles. So you can either, there is a Trendelenburg gait when person walks with this gluteus medius lurch, but it also a Trendelenburg test. We can actually test if the patient suffers from gluteus medius weakness or there is some other problem. In the real life, in the clinics, those muscles and those gait patterns are going to be assessed by physical therapists rather than occupational therapists. But nevertheless, it's good to know how to do it, what to look for, so you have a better understanding and appreciation where the patient is, what the patient can or cannot do, perform, and therefore, of course, you, from occupational therapy point of view, could help this person much better. If you don't understand the problem, if you don't understand what's involved in that problem, which causes bad gait or imbalance or unsafe transfers, then of course your ability as an OT are limited as well. So the more we know, the better we are, and the better off are our patients. So let's go to the next slide. Gluteus medius, short YouTube again. Gluteus maximus weakness now. Okay, so of course everybody knows where gluteus maximus is. This is the big muscles or our behind, and person thrusts trunk backwards to maintain hip extension, because again gluteus maximus is our powerful hip extensors. So what's going to happen if that muscle is partially paralyzed or very weak? We wouldn't be able to walk, period. So we can accommodate this somehow by using other muscles. So in this particular case, we thrust our trunk backwards. If we're going backwards with our trunk, automatically our hip is going into extension, right? You can try on yourself. go back with your trunk. What's happening in your hip? It goes into extension. So in order to accommodate the weak gluteus maximus, we are helping that muscle with our entire trunk. Again, you can see it, the gait is awkward, but it's functional. And of course, from occupational therapy point of view, we are working with functional rather than normal. So let's physical therapists work on improving the actual gait, but we are going to take this to different level, and we are going to work with these people, let's say, to be safe with toilet transfers, bed mobility, and stuff like that. Okay, so let's go to the next slide. Problems in stance phase with push-off. Osteoarthritis or partially or fully metatarsal phalangeal fused joint, and weak gastrocnemius soleus and flexor hallucis longus. Okay, so let's go to the next slide. Problems in swing phase with we're gonna go one phase at the time. So in this case, we're gonna talk about acceleration. So drop foot, we already talked about it, right? We already talked about that. There is no dorsiflexion. The dorsiflexors are very weak, and the foot goes down, which I already said, very common in CVA patients. So is this going to influence acceleration? Of course, without that high steppage, that high step, unusually high step, that movement wouldn't be even possible, because we would catch the floor and the person would fall. Weak quadriceps and fused knee joint, we already talked about those as well. For example, the fused knee joint, you will have to start hiking, meaning your pelvis would have to go to one side to accommodate and create the space between foot and the floor. Okay, let's go to the next. This is tighter drop foot, and person toes may drag to the weak dorsiflexors. We already talked about that, but this is just a picture or drawing representing that very weak muscle and the drop foot. Fused knee, we also talk about that. This is just a picture showing you how the person accommodate for walking with the continually straight leg, and that the hike of the hip to one side is actually absolutely necessary to clear the space between the foot and the floor. Okay, so let's go to the next. Problems in swing phase, mid swing. Drop foot again. So as you can see, the drop foot is a significant problem in all phases of the gait cycle. Steppage gait. Person may compensate by stepping high to clear foot off the ground if dorsiflexors are weak. We already discussed this. Those are our CVA patients, among others, of course. So steppage gait looks just like you can see on this drawing, on this picture, when the person is going to go very high with the knee in order to accommodate that very weak dorsiflexors, the drop foot, and clear the floor. And steppage gait YouTube, again, very short YouTube clips. Perhaps you can find better ones. Weak hamstrings. This is in deceleration phase. So hemiplegic gait. Hemiplegic gait, that's the one we already discussed with CVA patients, right? So you can see that the arm usually is contracted in the cases when people can use the lower extremities. Sometimes you're gonna see the upper extremity in flaccid positions, but a lot of times they're going to be contracted, just like the picture shows over here. And then the person is going to perform that steppage gait, which we already discussed, because the dorsiflexors don't work or they are very weak. So the foot is going to drop. So the steppage gait, when the person actually hike that knee very high to accommodate this. And in this also case, the weaker part, as you can see on this picture, the toes are inverted, and the step is going to be significantly shorter as well. Okay, so let's go to the next slide. Hemiplegic gait YouTube, so I advise you to just go on that. Ataxic gait, this is a really bizarre condition, and sometimes you can see this mild condition, and sometimes you see this in severe condition. So many times I saw this in mild condition, but once in my practice I saw that it's severe condition. So when the person actually stood up from her sitting position and started to walk, I literally jumped on my feet and grabbed the person, because I was positive that she is going to fall on the ground any second. Was that bad. The shaking was just simply incredible. So again, I think I have the short YouTube for you, so I advise you to go and find some other YouTube clips for yourself as well, just to familiarize yourself what is what. Basic ganglia gait. Basic ganglia, it's of course derives from the parts of your brain, and people who have this type of gait are usually people who suffer from either Parkinson's or Huntington disease. So what type of gait we're talking about is a shuffling gait. And for those of you who work with geriatric populations, you most likely have seen Parkinson's patients or patients suffering from Parkinson's disease, and they shuffle. What else? Decreased arm swing. So normally when you should walk, your arms should kind of walk with you on the side of your body, but with Parkinson's the arms are still, right? So that doesn't help your balance or the patient's balance, and the shuffling, very short steps gait is definitely different than what you expect. Basal ganglia gait, you got a YouTube. And then scissors gait. Scissors gait, when one foot goes too close to the other, or sometimes even crosses. So you got this scissoring. Okay, so again, in scissoring steps, one step is usually shorter than the other. So one leg is going to perform that stepping shorter than the other. Causes sometimes CVA, stroke patient, and sometimes multiple sclerosis. So you got different diseases, and those are just examples. Other people with other diseases, more rare diseases, can actually have similar gaits. So I'm giving you just, let's say, most common diseases, at least most common from my own practice. All right, and again, scissors is a YouTube I gave you as well. It's a very powerful short clip with scissors gait, so I do advise you that you copy and paste this on your browser and see that clip for yourself. It's going to explain a lot about scissoring and scissor gait. And this is it, guys. This was our last PowerPoint, last lecture. I do hope that you enjoyed my presentations, my PowerPoints. They are based on your book, primarily on Newman book, some Pedretti into that, some other perhaps pictures and drawings from other books, but nevertheless, it's all the material which you can find in Newman book. So I advise you to how to study. Again, of course, you already know this is it, right? This is our last lecture. But always go with your PowerPoint compared to the book. Make sure that you understand everything. And it was a pleasure, creating this short lectures for you. And good luck to all of you. Bye-bye.